Okay, we'll be looking at gestational diabetes, and even just before we can get there, just a quick recap on diabetes mellitus. This has type 1 and it has got type 2. Type 1 is juvenile onset, so that means it's usually diagnosed when the patient is young, whilst for type 2 it has got an adult onset. Type 1 is due to an autoimmune reaction where there's destruction of the beta cells in the pancreas, and ultimately we know the pancreas will secrete or produce insulin. Whilst when we look at our type 2, we're saying that there is insulin resistance, and ultimately there will be impairment of insulin function. Now, insulin is important when we have glucose in our blood for it to enter into our cells. This is a cell. For it to enter inside here, it has to be mediated by insulin. Without this insulin, we will happen to have high levels of glucose in our blood. So ultimately, type 1 and type 2 diabetes will lead to high levels of glucose in the blood or hyperglycemia. So high levels of blood glucose or blood sugar. Moving on to gestational diabetes. There's something before we even get there that's known as pre-gestational diabetes. For this pre-gestational diabetes, first things first, it happens in an already known diabetic patient or woman in this case, and usually the treatment will begin even when the pregnancy is less than 20 weeks. So the woman can be at 12 weeks antenatal visit and she's already on hypoglycemic medication. Then coming to our gestational diabetes. For gestational diabetes, first things first, this is diagnosed in pregnancy. So the first time that the diabetes is diagnosed is during pregnancy, and we can also define it by saying that this is diabetes that only happens in a current pregnancy. So this means if we have a woman, she's on her third child, and during all these pregnancies she was found to be diabetic, this is gestational diabetes. Whilst if we were to have a woman again on her third child and she's already a non-diabetic patient, she's already on treatment, in even at 10 weeks, we're now dealing with our pre-gestational diabetes. Okay, so let's look into the pathophysiology of this. What exactly is happening for this woman to have gestational diabetes? So first things first, let me just say this is the mother. This is the fetal placental unit, that's a placenta, and there's our baby. When we're looking at pregnancy, we're not just looking at one person, we're looking at both the mother and the developing baby. So the whole source of maintenance is coming from the mother to the baby. The baby will need an increase in blood supply. That's coming from the mother, going through the placenta, ultimately to the baby. So we need our nutrients happening here, we need our gaseous exchange and the like. And for energy, glucose is needed, ultimately leading to ATP. And the special thing about glucose, again, it's coming from the mother. Glucose has got the ability to cross the placenta through a process known as facilitated diffusion. So glucose is passing through from the mother, going to the child. Now remember what we just said. Here we're dealing with mom. We just said that glucose will need insulin to enter inside the cells. But then now we have a child here. We have a child who also needs glucose for energy for the child's basic development. So there will be certain mechanisms that will happen in pregnancy that will ensure that, okay, the glucose that's happening, that's inside the mother's bloodstream, we need some of it to go and cross over to the baby. So the placenta will produce this hormone known as human placental lactogen. And of course, there'll be other hormones that will be produced during this pregnancy, like your cortisol, your growth hormone, your progesterone, your estrogen. Ultimately, this will lead to some sort of inhibition or resistance to the glucose, because remember, we have mom and we have baby. So we need to ensure that some of this glucose that's there needs to cross over. Remember, facilitated diffusion is what's happening here, to the baby. That's the whole point of some of these hormones, just to help with how the glucose will be taken. Now, in gestational diabetes, what's happening here is that, first things first, there's an increase in the human placental lactogen. Of course, you've got your increase of other hormones, your cortisol, your estrogen, your progesterone, your growth hormone, and stuff like that. And at the same time, you've got a reduction in the whole insulin production at the level of your pancreas, or the mother's pancreas. This then in turn will lead the maternal blood to be hyperglycemic. So there will be high levels of blood sugar that's happening in the mother's blood. And one thing we should remember when we're dealing with DM, ultimately this will play a particular role when we start looking at what will this mean at the level of the child and the mother. We shouldn't forget our 3 P's, which is our polyphagia, which is an increase in how much will be eaten, our polydipsia, and our polyuria, which is an increase in urination. Okay, so just to run through that one more time, we have our mother and we have our baby over there, and this is basically the fetal placental unit. We're saying that gestational diabetes happens when there's an increase in the human placental lactogen and these other hormones, almost giving us some sort of type 2 diabetes picture, where there will be some sort of inhibition and resistance to insulin. And when with that happening, it means that insulin cannot easily be taken intracellular into the cells of mom. If that's not happening, we happen to have a picture of hyperglycemia, and ultimately this glucose will enter into the baby, making the baby too hyperglycemic. This is basically the pathophysiology behind what is happening in gestational diabetes. So let's look at what exactly will be happening at both the mother and the child. So let's just be moving from there, mother, child, or anyway, let's just see how we can go. We'll start with our baby. We have glucose that's coming in from the mother. So that's from the mother. It's entered into the baby. So this child will then be hyperglycemic. Ultimately, it will lead to an increase in insulin that will be produced. Because remember that insulin entering will facilitate the entry of glucose from extracellular into intracellular. And ultimately, this is what you should know. When you've got a state of high glucose, you've got high insulin, these two are anabolic. If you remember, you have anabolism and you also have catabolism. Catabolism is basically the breakdown, whilst this is the breakdown, whilst anabolism is the build-up. So we have glucose, we have insulin high inside the baby. This means that baby will begin to build up. We'll see an increase in the size of organs. And ultimately, we're going to see an increase in the size of the baby, basically due to the increase in insulin and the like. This is anabolic. So what happens? What do we call an increase in the size of the baby? This is known as macrosomia. Also defined as birth weight of greater than or equal to 4 kg or just 4,000 grams. First things first that you're going to see, there'll be macrosomia. Now, when we are, let's just say this is the baby, and let's say this is the maternal outlet, birth has to happen. The child has to get out from here. This through the whole labor process and the like. So the child needs to be delivered. But then we have a big baby and we happen to have a small outlet. So on the baby's part, on the fetal part, we're seeing that we're having macrosomia. What will it mean on the maternal side? At the level of mom, we're going to see that there will be obstructed labor. The child is too big for the outlet. They'll have obstructed labor or prolonged labor. Then there'll be risk of the shoulder of the child getting stuck during this birth, known as shoulder dystocia. The mother will be at risk of prolonged labor, obstructed labor, shoulder dystocia. Let's get back into the baby. Remember that this is a picture of hyperglycemia. And when we spoke of diabetes, there were those 3 P's. Your polyphagia, your polydipsia, and your polyuria. Now, we are looking back at the child. This is basically the amniotic sac. You have your baby here. We've already seen that there will be macrosomia, a big baby. Now, one of the other things that we looked at in diabetes was polyuria. Basically, there'll be an increase in urination. This baby, this dude here who's developing, will begin to urinate into the amniotic sac, the amniotic fluid. There'll be an increase in the amount of amniotic fluid that will be there. And what is this known as? This is known as polyhydramnios. We're going to see, because of the polyuria, there's going to be polyhydramnios. Now let's see what would that mean at the level of the mother. So we are examining a mother here. We're looking at her from on top. This is her face. This is basically her abdomen and the like. Remember when we say this woman has come for her antenatal care and she's at 28 weeks. When we're examining the abdomen of the mother, there's this thing that we get, the SHH, symphysial fundal height, and usually it will correspond at the point you're reaching 28, 29 weeks and the like. It's almost at a 1-to-1 ratio, where when you measure this SFH up to the pubic symphysis, if this mother is at 28 weeks, basically when you measure this, you'll get something like 28 centimeters. But now we have a big baby and we have polyhydramnios. This will mean she's come at 28 weeks. Hypothetically speaking, when we measure the SFH, we would find even something like 35 centimeters. So we'll have large gestation age, large for dates basically. It will not be corresponding. It won't be like an almost 1-to-1 ratio. Again, this is due to the baby being large and the increase in the amniotic fluid that is being produced. Let's go back to whilst was you here. Let's continue with this. So there's a topic known as PPH, and some of the risk factors of a mother, a woman having postpartum hemorrhage, is basically an increase in size. So here we have our pregnant woman and she has multiple kids. It's increasing the size of this whole pregnancy, so multiple pregnancy, and we'll have things like polyhydramnios, We'll have things like macrosomia and the like. So because of this increase, that's the contraction on the uterine and the like, this woman is also at risk of having PPH on the maternal side. Don't worry, afterwards I'll properly group these things. I just want us to see what exactly will be happening. So the PPH, the risk of it will be due to the polyhydramnios and the macrosomia. Now let's go back to the child here. So at the level of the baby, we had an increase in glucose. Ultimately, it will lead to it being taken inside the cells, and we know inside it will be used for metabolism. Now, when we're dealing with metabolism, ultimately there will be an increase in the oxygen demand. This increase in the oxygen demand, ultimately, remember the compensatory mechanism. If as a person, let's say here, whatever age you are, when you have an increase in your oxygen demand, as a compensatory mechanism, you increase your respiration rate, so you begin to breathe faster. If it's a chronic condition where you have an increase in oxygen demand and an increase in respiration won't really help, you will have an increase in, at the level of your bone marrow, you have an increase in the production of your cells. So this oxygen demand that's happening there will lead to the baby having polycythemia. We're going to see an increase in erythropoietin, and ultimately, so erythropoietin, which ultimately will lead to polycythemia. Whilst we're still on this, here's something that's a little bit weird. So insulin will also inhibit the production of lung surfactant. Your lung surfactant. So this baby will be at risk of having underdeveloped lungs. And remember, whilst we're still on the polycythemia, because of the whole amount of the increase in the blood sugar, your hemoglobin becomes bound. Hemoglobin, remember, is that weird structure where oxygen will be bound ultimately for gaseous exchange. Now, because we have hemoglobin, which is glycosylated because of the increase in glucose, the oxygen that will be bound to this glycosylated hemoglobin has got, of course, there'll be high affinity for this binding. There'll be high affinity for this binding, and unfortunately, because of this, there is low affinity for it to dissociate from this. Think of it like basically carbon monoxide, how it will easily bind to hemoglobin and it won't easily dissociate from the hemoglobin. So remember, we had the whole increase in metabolism, which was the oxygen demand, ultimately leading to polycythemia. Also here we're having, because of this glucose that's been attached to your hemoglobin, oxygen cannot easily dissociate. Ultimately, this will then lead to, because of the reduced dissociation, this will lead to hypoxia. And when there's hypoxia, ultimately, it will lead to polycythemia once more. And we're seeing how this is happening again at the level of the child. Now, when we have a hypoxic state, what will this mean? When we have a hypoxic state, what will this mean for the child? This child will be at risk of having intrauterine fetal death, just because of the reduced amount of oxygen that's going on and the like. So the child here will be at risk of having intrauterine fetal death. So just grouping them up properly for the baby, we've said that the baby will be at risk of having, or being large, microsomia. Apart from that, we said there'll be a chance of intrauterine fetal death. We're seeing that there will be intrauterine fetal death. We said there will be respiratory distress syndrome, remember the lung surfactant and the like. We'll have polycythemia. And there's this thing that will happen when this child will be born, yeah? So remember, glucose was coming from the mother, going on to the baby, And this led to an increase in insulin production in the baby so that the whole mechanism can be balanced. Now, what happens when the source of glucose is taken out? And how is that source of glucose taken out? Through birth. The glucose was never coming from the child, it was coming from the mother. But then remember that this child still has got high levels of insulin. And we said some of those things, the insulin was leading to a reduction in the lung surfactant and the like. So this child has got high levels of insulin and the source of glucose has been reduced. So ultimately this means the amount of glucose that this baby has, the amount of glucose that the baby will have will easily enter inside the cells because of high levels of insulin. And this, when glucose, remember we said when insulin is not acting, we had hyperglycemia. So the opposite would be true. Because of excess insulin, the glucose going inside the cells will remain with a state of hypoglycemia. Which means these children, immediately they are born, the baby should be rushed over to the NICU, basically. In this case, the neonatal ICU, NICU. Okay, so this child has just been born, and remember they had polycythemia, high levels of red blood cells inside the circulating blood of this child. It ultimately will lead to also high levels of hemolysis. And so these children are at risk of having high levels of bilirubin, which is basically jaundice. And another thing we should be worried about would be the connectorus. Okay, so at the level of the baby, one more time, we said that we're afraid of this child is going to be macrosomic. We said there will be polyhydramnios, there will be polycythemia, there will be hypoglycemia, They'll be at risk of intrauterine fetal death, respiratory distress, jaundice, and the like. How about for the mother? So for the mother, we said that there's at risk of having the same polyhydramnios. We said that there was risk of there being shoulder dystocia because of the large baby. They're also at risk of having C-section, delivering through C-section, because of, remember, the baby is large, the baby becomes larger than the passage, so ultimately this child cannot be delivered through spontaneous vaginal delivery, and the C-section will be needed for this child to be delivered. Then we said we'll have large gestational age when you do your symphysial fundal height. And remember, when you're dealing with renal issues, when we're dealing with renal issues, renal failure, or CKD rather, one of the risk factors for developing CKD was DM. So these mothers are at risk of having renal failure. And again, remember, one of the risk factors of having diabetes, there will be some sort of sclerosis of blood vessels, so they're at risk of having hypertension. So which means now when we're looking in pregnancy, these women are at risk of having preeclampsia, they're at risk of having pregnancy induced hypertension, which ultimately also will put them at risk of developing renal failure, or CKD in this case. And of course, they're at risk of developing diabetes. About 50% of mothers who have gestational diabetes will then develop diabetes. Then we said the obstructed labor. So just to write them properly again for mom, We said C-section, they can have renal failure, they can progress to have diabetes and coronary artery diseases, even diabetic retinopathy. They're at risk of having diabetic retinopathy. Yeah, so basically you're just thinking of what it means when there's high levels of glucose in your blood at the level of the mother and at the level of the baby. Basically, that's what's happening. What are the risk factors for a woman to develop gestational diabetes? When we're dealing with OBGY, always remember that a risk factor for any or most conditions will be that same condition itself. So, history of gestational diabetes. If you remember, we said gestational diabetes is one that is diagnosed during a current pregnancy. So a history of gestational diabetes, a family history of the same thing, gestational diabetes, a woman who is already diabetic, a woman who is obese, or rather the BMI is high, so we're looking at 30 kg per meter. We're looking at a woman with PCOS too, she's at risk of having this. A woman with a history of macrosomia, having a large baby, that is a risk factor. Okay, how is this then diagnosed? The diagnosis for this ultimately will be having high levels of glucose. So remember, from the WHO, our fasting blood sugar of greater than or equal to 7 millimoles, and our random blood sugar of 11 moles. You find this, ultimately you're thinking of diabetes. There are other oral glucose tolerance tests. The OGTT, where about 75 grams of glucose is given, and then they measure how much glucose will be in the blood after 1 hour and after 2 hours. Because this will be how you are diagnosing your diabetes. Now, just to go back a bit, one thing I forgot to touch on, remember that we said these children after birth will be at risk of having hypoglycemia, just because the source of glucose has been cut whilst there's still high levels of insulin. Whenever you are treating these babies, it's also important to know that certain medication, when you're treating the mother rather, certain medication that you're giving them shouldn't be able to cross the placenta. Imagine you are giving certain diabetic medication, let's say meds, and it was to cross the placenta and go to the baby. This baby would be at risk of becoming hypoglycemic. So the medication that's given is one that won't cross the placenta, such as your glyburide. Your glyburide, 2.5 milligrams per oral BD, because this won't cross the placenta. Now, when you are commencing your treatment of your diabetes, of your gestational diabetes, it's grouped into two. We have A1 gestational diabetes and we have A2 gestational diabetes. A woman with A1 gestational diabetes will have the treatment through diet and through exercise, whilst those with A2 are the ones who need your meds. And to touch back on what I said on the meds, this is where we're now having medication that can cross the placenta, such as our glyburide, 2.5 milligrams BD per oral. And whilst you are doing this, you are constantly monitoring the blood sugar. So always monitor the blood sugar of this patient. If they have a way of monitoring it from home, they have to monitor it and log it. Now, what happens, you've given this medication and you're finding, let's say the blood sugar is now at the fasting blood sugar is then greater than or equal to 8 millimoles. It means now we commence insulin. We begin to treat this patient with insulin. So on our insulin, in our first trimester, we are given 0.7 international units per kg daily. In our second trimester, just round it up, we're given 0.8 international units per kg, again once daily. Then in our third trimester, we are given 0.9 to 1.0 international units per kg daily. This will be how you are measuring, how you will be giving your insulin. So remember, the insulin therapy will only begin after you've started your first line treatment and you happen to find that it's not getting better, your fasting blood sugar is increasing. It was greater than or equal to 8 millimole. That is basically how you go about with gestational diabetes. And I think one thing I just forgot to touch on was on how the glyburide is working. So this is basically causing the pancreas to increase insulin secretion. Okay, just a run through all of this. We have mom and we have our baby. And we have the fetal placental unit that's there. So we're saying gestational diabetes, first of all, which was A1 and A2. We said A1 is that will require diet and exercise for its management, whilst A2 is what will require medication. Then we say the basic pathophysiology of diabetes, gestational diabetes, is due to an increase in human placental lactogen, of course with other hormones such as your cortisol, your growth hormone, your estrogen, and your progesterone, which ultimately will lead to some sort of type 2 picture where there's inhibition and some sort of resistance to insulin. This means that there will be high levels of glucose in the mother's blood, which ultimately will cross the placenta and go to the baby. Now, high levels of glucose will lead to high levels of insulin in the baby, which ultimately which we've said is anabolic, which ultimately will lead to the baby increasing in size, so which was macrosomia. And whenever there's macrosomia, you know that there's risk of C-section, there's risk of shoulder dystocia, and ultimately for the baby there will be a reduction in your lung surfactant, there will be polycythemia, there will be jaundice, there will be hypoglycemia. Then we said for the risk factors, there was a history of gestational diabetes. There's a family history of this same thing. We've said the woman who's already diabetic, history of macrosomia, delivering a macrosomic baby. We said having a BMI or rather obesity. Then on your diagnosis, it's done by investigating. We are looking at the fasting blood sugar and we are looking at the random blood sugar. And of course, with this, you can always do your oral glucose tolerance test with high levels of it, and you then begin commencing with treatment where your A1 and your A1 diabetes will respond properly to your treatment, to exercise and dieting, whilst your A2 will need medication. Okay, basically this has been on diabetes, gestational diabetes. Peace.